Okay, I'm Anita Murphy. I'm a diabetes specialist nurse based in Kings Lynn, and I'm the regional genetic diabetes nurse lead for the Eastern GMSA. I've been a genetic diabetes nurse for just over 10 years now. Just for those of you that haven't come across monogenic diabetes, and sometimes it's known as MODY, I'm just giving you an overview of what that is, and it is a very brief overview. Like type 1 and type 2 diabetes, monogenic diabetes limits the body's ability to produce insulin, causing a rise in glucose levels, which causes quite significant damage to the major organs of the body system, and we get microvascular and macrovascular damage from this. Unfortunately, people with monogenic diabetes often present with the symptoms of type 1 and type 2, so they're misdiagnosed from the start. Unlike type 1 and type 2, which is multifactorial, monogenic is, as the name says, caused by a single gene fault. It's a faulty gene, depending on what gene we're looking at, but it's a faulty gene which each parent has a 50% chance of passing on to their children, unless it's a mitochondrial disease, and obviously every child will inherit from that parent. So it's quite significant for a clinician working in diabetes to understand the difference between monogenic diabetes and type 1 and type 2, because treatment differences are quite significant. Okay. So misdiagnosis of monogenic diabetes has been going on for many years. So I've been around for 10 years, and the Exeter team have been doing this for 20 plus years. Monogenic diabetes accounts for about 3.6% of the diabetic population diagnosed under the age of 30. However, we do diagnose people later in life as well. Unfortunately, 80% of people with monogenic diabetes are misdiagnosed. That number is getting better, but as I say, we're approximately back 2 years data, we were at 80%. And on average, it takes 12 years from diagnosis of diabetes to getting the right monogenic diagnosis. That's quite significant because we make significant treatment changes to patients depending on what gene variant we identify. And there's always been widespread variation in referrals. If you look at this map, you can see, obviously, the Exeter team down in the southwest have been on this for many, many years, which is why they have a significant pickup rate. But the rest of the UK and Scotland significantly as well. Scotland ran a trial 6 years ago where they were they were screening every newly diagnosed type 1 for monogenic diabetes. They had a significant pickup rate. But the rest of the UK, unfortunately, is sporadic and it's been patchy. So what we're trying to do is increase our pickup rate and actually level out the playing field so that it's the same wherever you live, that you've got the same chance of getting picked up at the right time. The diagnostic criteria for monogenic diabetes: early onset diabetes, so diagnosed at a young age, ideally before the age of 25, and we do explain this to clinicians because they think they're only looking at their young adult clinic. The oldest person we've diagnosed with neonatal diabetes was in his 60s. The idea is the person in front of you need to find out when were they diagnosed, not how old they are presenting in your clinic. And obviously we're looking for a family history, ideally in 2 members if we can, but 1 will be enough to start. Now, if they have monogenic diabetes, they're not insulin dependent. Doesn't mean the person in front of you isn't presenting as a type 1 and is on insulin. What we'll need to look at is, can we measure C-peptide? So is that person producing their own endogenous insulin? If they are, and it's post-honeymoon period of being diagnosed with type 1, so at least 3 and ideally 5 years, then you're looking at more likely a monogenic diagnosis. As I've said, it's an autosomal dominant inheritance pattern, so we're looking at diabetes in the family. Does your mum or dad have it? Do you have a child? Do you have a sibling? Do you have a grandparent? What we're also looking at, because we are seeing many more young people diagnosed with type 2 diabetes, it's not generally seen in our population who are obese because they're often insulin resistant. So it doesn't mean to say if you're overweight that you won't have monogenic, but it's unlikely. So if we're looking in clinic, we will look for signs and symptoms of insulin resistance. So acanthosis nigricans, which can be dark staining on the back of the neck and under the armpits. And this is something we teach to clinicians. You do need to ask your patients to take the tops off in clinic. We need to be looking at areas we won't normally do. This has been part of our training, because if we can identify insulin resistance early on, then again it stops a pathway that we never need to send a patient down if we're thinking of a monogenic diagnosis. So as we've already established from other talks, we've got 29 trusts in this Eastern GMSA. We focused on the acute hospital trusts because that's where most of our diabetes specialists, consultants and nurses are based. Eventually we will move out into primary care because many people with type 2 are managed in primary care, but for now we're focusing on the consultants and specialist nurses that are in our acute trusts, which are 17 we're looking at. Our aims were initially establish a lead consultant and nurse in each trust in adult and paediatrics as a monogenic lead. Once we did that, and that took a lot of work initially, we then were set about advertising and encouraging them to attend the National 2J Monogenic Diabetes Training, which is run by the Royal Devon and Exeter team. And then finally, we set up a clinical network within the East GMSA for all diabetologists and nurses to attend. We run that 2 monthly, and the idea was it was a safe group in an informal environment to discuss cases, because many people have attended the training and then come along and go, I'm still not entirely clear. And that was something we recognised early on. So we've run those quite successfully. This is just a screenshot of our Future Learn space on the NHS website, and we advertise our regional meetings and obviously our monogenic diabetes course, and the next one is in the next 2 weeks. And then where we've been working towards is our pickup rate for referrals. So this last quarter, we've seen a significant increase in referrals, and I think that's reflective of the training, the attendance of the training and people's increased awareness of it. If you look at our average pickup rates, with all the testing that we do, we're averaging a pickup rate of a positive diagnosis of about 27%. For monogenic diabetes, the national average is 27.7%, so we're doing well. And what's reassuring to see is that people have attended the training, they've understood the framework they're working to, and they're sending in the correct people for diagnosis. We're not just going, oh, every patient in clinic now has got monogenic. They're actually thinking about it, and we're getting the right people referred in. So as I say, our pickup rate is increasing. We still need to improve that, but that's where we're focusing next. So our next steps and where we're leading to next is to identify, we've got 2 trusts left that we hadn't identified, an adult and a paediatric lead, although I think in the data I've just seen in this last week, I think we've got all of them now. We also want to focus on the trusts that perhaps haven't attended the regional meetings. And again, as we've talked about, clinical pressures out there at the moment are quite significant. So getting people to have the time to attend these meetings is difficult. We arrange them at a lunchtime, and we try and change the day, because for some clinicians they'll go, well, Tuesdays is our clinic day, we can't get out. So we will change the days around. So that's our next focus. So we will be emailing out those trusts that haven't had representation at any of these meetings. We'll then be making a sort of concerted effort to say, what can we do to support? Can we highlight this? What are we doing? And obviously what our aim is to continue to improve the diagnosis of monogenic diabetes. Our mantra has always been to get the right diagnosis at the right time, to get the right treatment. I haven't brought case studies because time was of the essence for this session, but we've made life-changing treatment changes for people. We've had people we've taken off insulin, who've been in insulin for 30 years. And you've had 30 years of 4 injections a day, finger pricking 6 times a day. It's significant, and it's significant for the families. So we're passionate about what we do, and the clinicians we're getting on board are as well. So it's been really, really good, actually. And the East GMSA has been really supportive of our work with this. So I'd like to take this opportunity to say thank you to them as well. Lovely. Right, thank you very much. Obviously, any questions, scan the code.